Good evening and thanks for watching. I'm Erin Hawley in the KATV studios. This is the fifth in a series of webcasts focused on your health that KATV is producing in partnership with CHI St. Vincent. I'm joined tonight by Dr. Raj Chakka, a cardiologist at CHI St. Vincent Heart Clinic in Little Rock. And over the next half hour, we'll be focusing on heart arrhythmias and treatments. We'd like to answer any questions that you might have, so we invite you to submit those right here in the comment section of the web stream, and we'll do our best to answer those questions. So Dr. Chakka, thanks so much for being here.
Thank you for having me.
To start off, what is a heart arrhythmia?
Abnormal rhythm. Rhythm is what keeps the beat, the ticker going. And arrhythmia is abnormal rhythm. It could be different types. It could be from the top of the top chambers or the bottom chambers. Some of them are inherited. Some of them are acquired. Some of them are serious. Some of them are not very serious.
Right. How common is it for someone to have an arrhythmia?
It depends on the type of the rhythm and the population we're talking about. If it is atrial fibrillation, it is fairly common. And especially with age, about 1 in 10 people over 80 have atrial fibrillation. And heart attacks are a very common problem, and they cause low pumping function and damage to the muscle. Then subsequently that in turn causes electrical abnormalities and rhythm issues like ventricular tachycardia that in turn can cause cardiac arrest and sudden death and things like that.
So when we're talking about, when you mentioned AFib, that's a type of arrhythmia.
Yes.
So there are many different types of heart arrhythmias. Some of them we're going to be more familiar with, some we aren't. What are some of the other names that people might recognize?
Supraventricular tachycardia, which would be SVT, is very common in otherwise healthier younger people. And some of them could be even in children. And sometimes people say like they had it as a child and they didn't know what it was, and then later in life sometimes people come with SVTs. And the other one that is very important is ventricular tachycardia. It's called VT, or ventricular fibrillation, which is VFib. VT and VFib usually are the causes of the cardiac arrest. And sometimes they can happen, like I said, after some damage to the heart muscle. And there are other conditions where people kind of inherit them, and they might be otherwise very healthy people, may not have any kind of other medical issues, can have some serious consequences like sudden death.
And you also mentioned this can happen at any age.
Yes.
All of the different age groups could be affected. This is something that could be brought on. It could be something that you're born with.
Yes.
What are those situations?
Well, the ones that you're born with are, there are two different types. The one where you actually have an abnormal muscle bundle, more structural, where a lot of them, for example, SVTs are caused by that. Those a lot of the times can be ablated, meaning you can actually fix them and cure them. There's very few conditions in medicine that we can say it's cured.
Right.
SVT ablation could be one of them. And
before we get too much into how to fix them, let's keep going through how you know you have it. What are some of the risk factors?
The symptoms, first to address the symptoms.
Okay.
It might be something very benign, like a little fluttering in the chest and somebody feeling little something funny, or to racing of the heart or pounding, or sometimes feeling simple extra beats like as extra thump, to a little bit more symptoms like people may have a shortness of breath when they try to do things, or chest pain or chest discomfort, to people feel like dizzy or feel like they're going to pass out or potentially pass out. And in more serious ones could be not just simply having a fainting spell, but can have more serious cardiac arrest and things like that.
Right. How serious can this be other than just cardiac arrest? What else can go wrong?
Well, if somebody passes out and they couldn't catch themselves and fall and hit their head on something or break a hip, that would be a problem.
Yeah.
And or if somebody is doing something where suddenly if they got caught off guard, it could be dangerous, like somebody biking or running on a treadmill suddenly have a problem and lose balance and dizzy and fall would be serious.
Right.
And it could hurt that way, but many a times most of the other rhythms usually people have enough warning that they can sit down and take care of themselves and not have serious injury.
Sure. And some of these symptoms are things that you might not notice.
Yes, yes. And one of the ones that more serious one that people may not notice is atrial fibrillation. Some people, the first time they roll into the ER with a stroke is the first time they ever heard that they have atrial fibrillation.
Right.
And many people feel there's something abnormal in their heart rhythm. Some elderly people or even like younger people sometimes occasionally may not be able to tell that they have AFib, and then they show up in the ER with a stroke and they were told they have atrial fibrillation.
Let's take a closer look at AFib and how it can be treated.
I would have shortness of breath. I would have, I could feel my heartbeat. I was very aware of my heart rate, being irregular.
Those symptoms led Dana Trawick to Dr. Tom Wallace, a cardiac electrophysiologist with CHI St. Vincent.
Most of the time, patients who have electrical issues have palpitations, so they'll feel their heart fluttering or flipping or flopping.
The retired school teacher from Hot Springs has atrial fibrillation. Trawick isn't alone. Dr. Wallace says AFib is very common.
It's become an epidemic, especially in folks as they age. Ages 60 or older, we're seeing it more and more and more. And it's caused by all kinds of issues, from obstructive sleep apnea to an overactive thyroid. Sometimes it's just a condition that the heart has as it ages.
The meds and the ablation have controlled my AFib. I don't have any issues when I exercise now. Quality of life is great.
With treatment, she's been able to get back to working out and encourages others with AFib symptoms to get checked.
I feel great. I feel really good. That's a gift.
So how does AFib differ from other arrhythmias? You said it can almost be a symptom of other arrhythmias.
Some of the other rhythms are more regular and could be even more rapid than atrial fibrillation. Like SVTs sometimes could be in younger people more than 200 beats or 180. And they're more regular. Whereas AFib is more chaotic, more irregular, and symptom-wise, also onset. Sometimes the AFib may be lingering. It may you may not feel like it's abrupt onset, abrupt ending because it's more irregular, and extra beats could be coming even before AFib comes. Whereas SVT, many a times it's like more on-off, like switch on, switch off, more often than not.
So AFib is going to be something that you're going to notice a lot more than possibly some of the symptoms of just a typical arrhythmia.
It depends on the person and the situation. I don't think I can say that.
Sure.
Some people, it's more common for people with AFib not feeling it than people with SVT.
Okay.
People with SVT very rarely may be having not very rapid SVT, but it's a little bit slower, like for example, let's say 120 beats a minute. They may not be able to tell. The first thing we know is like their heart became weaker and they developed congestive heart failure from having SVT for a long time that they did not feel. Happens occasionally, but not as common as AFib.
Right. One of our viewers, Monica, has asked the question that's along the lines of this. So she has some fluttering. It's gotten worse. So at what point do you notice it? At what point do you worry?
It'd be good to diagnose.
Yeah.
I think most important thing is have a diagnosis. If you have a diagnosis, if there's a few extra beats, nothing to worry. Once you know, hey, I have extra beats from the bottom called PVCs, or I have some extra beats from the top called PACs, any of those specific diagnosis, once you know, okay, this is what I have, it's not very serious, it's some nuisance, don't worry about it. That would be nice. Not having a diagnosis is a problem. We don't know what one has. The most common things we do for that is put a monitor. And the monitors in olden days used to be clunky and have actual leads, and you can't take a shower with them, and you have to carry it like a pager, and it's a lot cumbersome than the new ones right now. The one that we use in our office right now is simply like a Band-Aid, essentially. And it doesn't have any leads. Everything is built into one little strip, and you can take a shower with it. You can even wear it for like up to 14 days. So sometimes people wear it for a day. They may not have anything on that day, the monitor would be negative, then they still don't have a diagnosis. The newer monitors, if they can wear it for like a week or 2 weeks, have enough episodes, it's a lot more, you have a lot more validity to say, okay, this is serious, this is not serious, this is what you have. It's a lot easier to tell.
So it sounds like this isn't something where you can go into your doctor's office and you can do a simple test and know before you leave that you do have an arrhythmia or you do have AFib, that sometimes you have to wear this patch for a little bit longer. How long might that be?
Well, so we still start with a simple EKG in the office.
Okay.
If somebody is having some extra beats, if we can catch it on an EKG and we can characterize it and tell them, that will be the easiest way to do. It's a simple enough test. EKG takes just a few minutes. If that doesn't tell, depending, we usually go by the history, how often they feel. Is it every day? Is it once a week? Is it once in a couple of months? And depending on that particular situation, then you have to say, why don't you wear it for a week or 2 weeks? Or occasionally we may even put people on a monitor for 30 days where they can press a button when they feel something and actually correlate their symptom with what they find on the monitor. And in a situation where somebody is passing out, but that happens once in 6 months, then even that monitor won't work. In those scenarios, we use a small monitor that we actually implant. It has battery for that lasts up to 2 years, and they have a remote that comes with it. They can, if they feel something, they can press a button and date and time stamp it, so we can see what happened at the time. Or even if somebody passes out and like somebody else can press the button and we get to record what's happening exactly at that time. Is it slow heart rate, fast heart rate? We've been talking about fast heart rates a lot, but sometimes arrhythmias are slow heart rate.
Okay.
Their heart rate is too slow. Their native pacemaker cells are not firing as good as they should, and there might be pauses in their heart rhythm that they can pass out. That's also an abnormal rhythm, not having a rhythm.
Yeah.
So it's called bradycardia. Slow heart rate is bradycardia.
Okay, so we've got tachycardia and bradycardia.
Exactly.
So you can go either way.
Yes.
And
going back to Monica's question,
Yeah.
just to answer, in her case, if she doesn't know what she has, the best thing is maybe wear a monitor for a little bit longer than what she wore before, if she already did. And could it cause anxiety? Yes, most definitely. And unfortunately, I see this more in women than men, even though it can happen in anyone. Traditionally, when our society, I guess, hopefully now it's different, at least in the past, like women were told you're anxious more than saying, let me look into it. And occasionally I see a patient who are in 40s have been on benzodiazepines or Xanax and medications like that for anxiety all their life because that's what they were told. All that they have is
that it was
simple.
an anxiety problem and not an actual arrhythmia problem.
Yes.
Interesting. So this is something that could be caused by anxiety, but it can also cause anxiety, or anxiety may not be a factor in it at all. It just may be a misdiagnosis.
Well, I mean, a lot more people have anxiety as an anxiety. That's probably the more common. But there are enough people who may have some rhythm problem that might be perceived as an anxiety by them or the physician.
Right. Makes sense. Okay. Well, that was a good question from Monica. Thank you for that. So moving forward, we've talked about the bradycardia, tachycardia. So how do the treatments differ as far as whether the heart rate is too fast or too slow?
If the heart rate is too fast, either we can give some medicine to treat it, either slow it down or control it, manage it, or we can have a procedure to fix it occasionally, like it's called an ablation, where we actually go from the groin with the noodle-like catheters, snake them up the blood vessels, and do some testing to figure out what's going on, where is it coming from. For example, if it's an SVT, if they're born with an abnormal electrical tissue that they're born with, if we can find it and you can cauterize it or ablate it, you potentially can get rid of it. That might be all that they need ever, like no more medicine ever in their life.
And you make that sound like not a big deal, that procedure.
Well, procedure, I wouldn't say that. I mean, any procedure can go wrong. I mean, some simple IV can get infected and land somebody in some bad infection in the hospital.
Right.
I wouldn't take anything as too simple. but at the same time, it's fairly common procedure nowadays. Technology is getting better every day.
Sure.
We have a lot of tools, and it can be done with a very reasonable risk.
And so that can be done to fix both kinds?
No, predominantly that is for the tachycardia
Okay.
or the fast heart rate. The slow ones are typically helped with the pacemaker, because we really don't have any good medicines to give for slow heart rate. They're predominantly addressed mechanically with the pacemaker.
Okay.
And but we do have some new pacemakers.
Technology is evolving every day and making these things easier to treat.
Yeah.
Okay, we have another question. This one is from Thomas. Can you accept a PDF copy of a personal EKG for a question on a visit? So I'm not sure how you would do a personal EKG, but maybe you have one from another doctor's office and you want to take it for a second opinion, maybe something like that.
Sure. I mean, we always don't want to waste any information.
Yeah.
Like if somebody has a documented EKG that they have found a problem, it's a lot easier to go by that information than try to reinvent the wheel.
Okay. Another question coming in from Carolyn. Why do ads on blood thinners say not to take if you have experienced valve replacement? So why would you not want to take blood thinners if you've had a valve replacement?
People who, I think, Carolyn, I'm assuming that you're talking about the new blood thinners that are indicated only for non-valvular atrial fibrillation.
Okay.
The new agents are very popular nowadays, where you don't need to do testing of the blood thinner levels or the PTT or INR, we call it. The new ones were studied in people who have non-valvular atrial fibrillation. Doesn't mean they cannot work in people with valve issues and valve-related atrial fibrillation. They were not studied in that population. Right now, the FDA indication for the new blood thinners or for non-valvular atrial fibrillation. Again, within that context, there are a lot of details, like which valve. Like a lot of the people, when they say non-valvular atrial fibrillation, they're really referring to mitral valve problem.
Okay.
And if someone has, for example, some aortic valve leak, doesn't mean they cannot take the new blood thinners. So there's a lot more subtlety that goes into it. So you may want to, if that is your situation, you may want to talk to your doctor and go a little bit detail into your personal situation and see if you might be able to take the new ones.
Okay, very good. We also want to talk about a new type of implant that you have, the microtrans catheter. Tell us a little bit about this. This is coined as the world's smallest pacemaker.
It is a leadless pacemaker.
Okay.
A typical pacemaker goes in the chest with the leads going through the blood vessel into the heart. The generator and the battery, the computer and the battery, are really sitting inside the pacemaker that's sitting on the chest, communicating to the heart chambers through the leads or the wires.
Right.
Whereas a new leadless pacemaker does not have any lead. It looks like a little capsule that you take, like the medicine capsule that you take, and it is implanted right in the heart itself. The computer, battery, and the electrode, everything is built into a little capsule that we take it from the groin blood vessel, go into the heart, and implant directly in the heart. It's tiny. It's about 1 cc volume. It's called leadless pacemaker.
Wow.
That's a micra.
So the smallest one that's ever been made, fairly non-invasive, as much as you can get.
Yeah, you're really not cutting having an incision up here.
Yeah.
You're really going with a tiny incision through the groin blood vessel. Just like, for example, if somebody has an angiogram or a heart cath, that's the size of the incision in the groin.
And we keep talking about the size, but why is that important?
Well, like a lot of the people are very active nowadays, and they may not want to have a big pacemaker sitting in the chest and a scar, and the also like the psychological effects of it. A lot of these things, just because somebody has slow heart rate, they may have a very active lifestyle. They don't want this to psychologically drag them down. And in an appropriate situation, if they're a candidate for a leadless pacemaker, they might better adjust to it.
Right. And as you mentioned, the way that you implant that is also different from a traditional pacemaker and a little bit less invasive.
It is less invasive and also less hardware. The more hardware you have, more problems you can have.
That makes sense.
The leads are the usually in the typical regular pacemaker situation, the one that goes wrong when it goes is usually the leads.
Sure.
And also it is harder to deal with. The pacemaker, if the computer, something is wrong with the computer, it's a lot easier to take it out and put a new one. But if it's a lead that's been there in the blood vessel for like 5-10 years, it's a lot harder to deal with it.
Yeah.
So the newer pacemakers, if they don't have a lead, that much less problem.
Makes sense. Okay, we've got a couple more questions from viewers. Mark is asking, can part of the top of the heart be cauterized to fix it? So I think that's what you were talking about, the ablation.
Yes.
Is that right?
Yes.
And so that depends on where the issue is, and you guys go in and find that and then cauterize that part of the heart.
Exactly.
Why does that fix it?
Well, it depends on if it is like, for example, some cells abnormally beating, meaning like a wannabe pacemaker cells. The only cells that you want automatically triggering and giving you the electrical signals is your pacemaker cells. If they're, let's say, an area that's acting up and wants to give the beats, sometimes that's going to conflict with your normal pacemaker rhythm. So sometimes in that situation, we might be able to find that area and just cauterize that area and be gone. Or somebody may be born with an extra electrical connection between top and the bottom. Typically, normal heart has only one connection right in the middle.
Okay.
That's the only electrical communication between top and the bottom. If somebody is born with a second one, now you have two pathways. You can make a loop, electrical loop. If you go in the loop, if that loop goes 180, your heart is going to go 180. So in that situation, you can go find where the abnormal pathway is and cauterize it. So the extra one is gone. So you only have the normal one remaining.
Wow.
Yeah.
Brittany has asked, why would a person who is not in shape have a resting heart rate of 49?
It's a very good question.
Really good genes?
Yeah. It also, sometimes it's good, sometimes not.
Yeah.
And if sometimes if somebody is at 49, if they're not in, it depends on what age. And if they're younger, if they're at rest, if they're 49, that's fine. That's great. Okay. And even if they can have it, like you said, maybe good genes and their natural rhythm. But when they get up and walk, their heart rate is supposed to go up to support their activity level. But if it doesn't go up with their activity, then that's a problem.
What could that mean?
If somebody wants to run, if their heart rate from 49 is not going, let's say their body is asking for 80, they don't go to 80 or 100, whatever their body's activity level is asking for. If they don't go, then they could have symptoms, like they could feel dizzy or lightheaded, or they can feel fatigued or tired or short of breath when they're trying to do activity, any of those things. Occasionally, elderly people are in that situation. Their heart rate doesn't go up. It's called sick sinus syndrome, meaning their normal sinus cells are sick, and occasionally they may need a pacemaker.
Interesting. But if your resting heart rate is 49, but when you do activity, your heart rate does go up, more than likely that's
You're
okay.
That's okay if you don't have any symptoms.
Okay. She has a second question. Is mitral valve prolapse low resting heart rate and low resting heart rate, are those connected?
Wow, that's a difficult one, because mitral valve prolapse is such a prevalent problem. It correlates to so many things, and that's not a typical thing that I see, that combination.
Yeah.
But you can have it. Nothing to say you cannot have it. If somebody like Brittany has that, that's okay.
So maybe not connected, but you could have both of those.
Yeah, it's not anything concerning.
Okay. Ina is asking, is Sotalo a good medication for AFib? Are you familiar with that one?
Yes, sotalol is their half a dozen medicines that we use for atrial fibrillation.
Okay.
Sotalol is one of the older ones, one of the common ones, and it depends on the person's situation. Like AFib is one of those conditions you want to tailor your treatment to the individual person. Sotalol might be a great medicine for one person, might be a really, really bad medicine for somebody else. It depends on the individual health history and their situation.
And that's why you want to always ask your doctor
Yes.
what they think for your individual case.
Yes.
We've got one more question. Candy is asking, can SVT episodes cause damage to the heart?
Yes, and most of, I want to preface this response with saying most people, if they're having an occasional SVT episode once in a while, it bothers them, they're a little anxious, their heart rate is going fast, but they don't have any other symptoms, that's okay. It should not cause any long-term damage or a problem. On the flip side, I was alluding to earlier, occasionally we see people who've been having so much SVT that their heart is overworking for prolonged periods and can get tired. And in that situation, you may develop what we call tachycardia mediated cardiomyopathy, meaning the fast heart rate is causing the muscle abnormality or muscle dysfunction, cardiomyopathy. The way they do that, it can happen is the muscle can get stretched out, enlarged, and lose some of the pumping function, can potentially develop congestive heart failure. That's not very common. I want to tell Candy that I don't want her to lose sleep on this. This is not the most common. This is not the most common way that happens, but can happen.
So again, that's why it's important if you think you might be experiencing some of these symptoms to talk to your doctor and make sure that you've been diagnosed and that you're on an appropriate method of treatment.
Yeah.
Okay. Well, Dr. Chakka, thank you so much for joining us tonight.
Thank you so much.
We really appreciate it. We appreciate CHI St. Vincent for partnering with us on this, and we thank all of you for joining us. Have a great night.
Good night.